Okay. Hi, everyone, and thank you for joining us today. We're excited to be having another learning opportunity from the California Telehealth Resource Center. And today we have a really relevant topic, super timely. We are going to be talking about COVID-19 PHE termination and impacts on telehealth. We're going to be joined by some wonderful experts from our parent organization at OCHIN. Go ahead, next slide. Some tips for today on Zoom. You have been muted on your entry, but you are encouraged to use your video. We'd love to see your face during the session today. It's always helpful. We are also going to encourage you to use the chat as much as you can. Ask your questions. If you have any comments on any information shared, please feel free to use that chat as much as you'd like. And then you'll also notice that we are recording today's session, so that will be made available very soon. And then a quick disclaimer for today, as usual for CTRC, we are here as a resource center, so everything that we're sharing is for informational purposes. CTRC does not provide legal advice, it's just for information. Also, if any products or services are mentioned during today's presentation or any of the conversations, know that there is no relevant financial interest, arrangement, or affiliation. Again, not trying to sell you anything, we're just here for information. Next slide, please. And with that, I'm going to introduce our wonderful presenters for today. We have Sylvia and Becca from OCHIN, and I'll let you guys introduce yourself. Thank you so much for your time and effort today.
Thank you so much. Really happy to be here. Hi, everyone. I'm Becca Brooks, an improvement advisor here at OCHIN. I will be moderating today's conversation, and the bulk of our information is going to be shared by Sylvia Trujillo, who is the Senior Director of Policy for OCHIN and does a lot of work supporting the CTRC and the California Telehealth Network. She was appointed by the California Department of Healthcare Services to the Medi-Cal Telehealth Advisory Work Group in 2021. And during her 13-year stint, yes, that's 13 years, at the American Medical Association, she advised on federal legislative and regulatory policy related to virtual services, including telehealth, while also staffing the AMA's Digital Medicine Payment Advisory Group and the CPT editorial panel. So a wealth of knowledge here, and really looking forward to all she has to share with everyone. Go ahead and jump to the next slide, please. Great, thank you. So as we are all aware, I'm sure the COVID-19 public health emergency did sunset last Thursday on May 11th, 2023. So as the PHE concluded, many waivers and broad flexibilities provided to healthcare providers as a result of the PHE were either modified, extended temporarily, or terminated. Really important to call out here, there are federal flexibilities and then there are state-specific flexibilities. So we'll be focusing on California. Sylvia is going to talk through more of that, but that's what we have in store for you all. I'll be keeping an eye on the chat. We'll have plenty of time throughout this presentation to address questions. If we don't get to everything by the end, we'll be able to answer those via email and send those out post this session. But with that, I will go over and hand the mic to Sylvia.
Great. Thank you so much, Becca. And I want to thank everyone who's here today who sent in questions early on. You'll find that the presentation is really geared to answer many of the questions. However, please add your questions into the chat function, and Becca will be calling out questions as we go along. I'm going to hope to have some time at the end so I can field any additional unanswered questions. If we don't know the answer, we will find it out and get it to you. So there are some pretty big changes, but I want to level set first because there continues to be and will probably remain a lot of confusion around the term telehealth and what we're talking about today. So as many of you already know, both state and federal programs use the term telehealth to mean a lot of different things. We are really going to focus on what payers, and in this case, it's going to be federal healthcare programs like Medicare and Medicaid, as well as commercial payers mean when they say telehealth. And we are doing that because it turns out many of you are interested in what services you can get reimbursed for and what are the coverage policies that govern it. You also are interested in whether or not there are additional regulatory requirements around things like prescribing using a really specific modality. So I'm going to offer here today on slide number 6 that we are primarily going to focus on a service and modality that is intended to replicate an in-person visit using an interactive technology, whether it's interactive audio and video or audio only. So this is the term that traditional original Medicare, for instance, uses when it uses the term telehealth. I will talk about a couple of other modalities, remote patient monitoring, e-consult, store and forward. I have a big X on the bottom on here so that you all, as you go through and get this as a resource, will understand that the vast majority of what's contained in the presentation is not talking about remote patient monitoring or e-consult and store and forward. And we're happy to have a presentation on those modalities in the near future. I will have some information specific to Medi-Cal on those topics here, but because of the vast number of things we're going to cover today, we're focusing on telehealth. So with that, if we can move to the next slide. To give you a full sense of the themes we're going to talk about, in the questions we received, we were getting questions that concerned regulation of clinical practice, like licensure, prescribing, and also whether or not your platform is HIPAA compliant and secure. These are regulatory questions and they apply across payers. So these are going to be true whether you're talking about a Medicare beneficiary or someone who has Cigna and is a commercial paid patient or managed care. These are the rules of the road, like on a freeway, that everyone has to adhere to. So that's the big orange one. We're going to start with that one. But I also want to flag that there are other government programs like HRSA that has additional requirements around telehealth specifically. We're going to cover those today. And then last, there's a whole slew of payer policies. And there's lots of different payers. There's Medicare, there's Medi-Cal, and there's commercial payers. We're going to focus today primarily on Medicare and Medi-Cal. Okay, with that, next slide, please. So in the chat, if folks could go ahead and this is just an answer, let me know how many of you or your clinics or organizations you're affiliated with have clinicians who are FDA, DEA registrants and prescribe controlled substances. So we'll get a sense of how many folks are going to be impacted by changes that will be forthcoming with regard to DEA regulation. So with that, we're going to go ahead and move to the next slide while we get answers to that question. So for those of you who are indicating yes, that you have clinicians who are registrants under the DEA to prescribe controlled substances, you will probably recollect that prior to COVID, telehealth could not be used to initiate or establish a valid patient relationship. You had to instead have at least an initial in-person visit. Then when COVID hit, the public health emergency waivers were put in place and the DEA, SAMHSA, and HHS, if we go to the next slide, went ahead and said, we are going to go ahead and allow telehealth, both interactive video for the controlled substances listed here to establish a relationship. Now, remember, I'm saying establish a relationship. If you already have an in-person relationship established, you can use telehealth. You can use interactive video telehealth, both pre-pandemic and currently. This really is about establishing a relationship and you have to use interactive video. Well, during the pandemic, we're going to move to the next slide. There was a decision that we're going to go ahead and we're going to go beyond the in-person requirement for establishment. We're going to allow for telehealth to be established through interactive video. So that's going to be our next slide. And I also want to provide this one little caveat. in California, the flexibilities provided in the state for prescribing of controlled substances is as liberal or permissive is probably the better word as the federal law allows. So it turns out for prescribing, there's a federal law for prescribing of controlled substances, and there's also state laws. There are other states that we're not talking about today because it's a CTRC, but there are other states that have more restrictive prescribing laws than the federal law. And you just need to be aware of that if it turns out you're located in California and you're licensed somewhere else and you're registered someone else and you're prescribing there. But during the public health emergency, the DEA said you can initiate using interactive video, and we're also going to allow you to initiate using audio only telehealth if you're prescribing buprenorphine for the use of opioid use disorder. And you'll all understand and know why that's the case. It's because we also have a public health emergency involving opioids. And so everyone was concerned that on May 11th, that we would have a situation where all of these flexibilities would lapse, and this would have pretty catastrophic impacts on patients who had not had an in-person relationship with their clinician. So if we move to the next slide, the DEA, after a lot of pressure earlier this year, issued a proposed rule. And in that proposed rule, they identified a series of flexibilities that would be extended, but most significantly, they said that there would be only about a 30-day period of time that you would have to have an in-person appointment if you initiated via telehealth before you could continue using telehealth. So let me say that again because it was confusing. They had proposed, yes, we will share the slides, that you could initiate with telehealth, but within 30 days, you would have to have an in-person if you wanted to continue thereafter with telehealth. So thank you for moving to the next slide, because this captures that we, along with many other organizations, including the California Medical Association and about 30,000 others, submitted comments saying this is going to have a catastrophic effect. This is particularly disastrous for patients who had been initiated on buprenorphine for opioid use disorder, who oftentimes would have difficulty within that 30 days finding an in-person appointment given shortages and their health status. And initiating and then discontinuing actually has demonstrated to increase mortality and morbidity. And so we anticipate, if we go to the next slide, as a result of a final rule that was issued, and I apologize for the size of this, it's quite small, and yes, you will receive the slides so you can take a look at this. But the DEA has basically kicked the can down the road and punted until November 11th of this year, where they've said, we are going to issue a temporary rule where you can continue to prescribe as you have done during the public health emergency. However, on November 11th, you are only going to have those flexibilities for another year for those patients you've already initiated prior to November 11th, 2023. Now, many of you have asked about, we've heard about deadlines and we've heard timelines. We're going to have a beautiful set of deadlines and timelines for you guys to see, but I'm going to call this one out for you guys to take a look at. This one concerns the DEA flexibilities. So if you have clinicians or you're a clinician that's prescribing controlled substances, you need to really carefully look at these timelines and get ready. So our next slide is basically where it's feasible, you should consider scheduling those patients for an in-person visit before a November 11th of this year, so that by November 11th of 2024, all of your patients or most of your patients will have already been seen, because that is when all the flexibilities go away. So for some of you, this will not be possible. So we are going to continue to advocate very vigorously with many other stakeholders to retain the full panoply of flexibilities available under this proposed rule. Okay, So we're going to go pretty quick hereafter. I'm just going to highlight on the next slide that California laws are more permissive than federal laws. So because the federal law has more stringent, you have to follow the federal one in this case. But in California, we're fine with the flexibilities without having to advocate for additional changes to those. So let's move to the next slide, slide 18. So we were going to focus primarily on the DEA proposed and final rule, but the scope of questions we received really followed a broad range of topics, all the way from HIPAA compliance with your platform, whether or not the Office of the Inspector General is going to do enforcement discretion for copays, and then a whole host of payment issues. So we're going to move to the next slide, and we are going to take a look at HRSA specific issues and OIG specific issues and what has changed. So going to the next slide, if you are using currently a HIPAA non-compliant platform, so it's not a secure platform, until now, the Office of Civil Rights of HHS has exercised what's called enforcement discretion. They said, basically, we're going to look the other way. They have now said that you have 90 calendar days in order to transition to come into having a compliant HIPAA secure platform for telehealth delivery until August 9th, 2023. Okay. This will be added to your slide of deadlines that you need to be hitting. So let's go ahead and move to your next slide. So the Office of the Inspector General. So, and I want to make it clear, both of these apply to a broad range of providers, regardless of who your payers are, right? So keep that in mind. So if you look at this one, government healthcare programs, we're going to talk about the Office of the Inspector General. So this is often talked about in the context of Medicare payments. This is about co-payments. So up till now, the Office of the Inspector General for HHS said for federal healthcare programs, you do not have to charge co-pays. So this not only applies to telehealth, but it applies to some of the other virtual modalities, which remember, going to put those off to the side, but because this is an important issue, I'm going to flag right here. The other virtual modalities like remote patient monitoring and e-consults, you can no longer waive those copays if you're obligated under the current program structure to charge those copays, right? So we're not talking about in a HRSA FQHC setting where you can apply a fee schedule, right? We're just talking a blanket outright not collection of copays for everyone, regardless of ability to pay. That was the case during the pandemic. You didn't have to collect copays. That is now changed. So effective immediately, you need to have in place your processes for determining whether or not a copay is applicable and then charging that copay. Okay. So let's move to the next question. How many of you are providers, are clinicians, or part of providers that participate in HRSA programs? Okay, so we have quite a few folks. So HRSA, as many of you likely know, also implemented a series of flexibilities. And these flexibilities aren't exactly like the Medicare flexibilities, but you're going to see that HRSA actually tried to coordinate with Medicare to align some of their deadlines around their flexibilities. And essentially, the flexibility they put in place relates to service areas and the services where telehealth can be used. And the key one is around your service area, because as you know, during the pandemic, the limitations around the service areas that could be served were waived. So even if your patient was not in a designated service area or an adjacent one, you were permitted to provide a telehealth service to that patient if they were located outside of that area. That permissive waiver allows that to continue until December 31, 2024, unless HRSA issues some clarification or guidance before that time. Now, at this point, your head is spinning. I've provided a lot of different dates and times. So in your slide deck, what you're going to get, if we go to the next slide, is we have here the DEA deadlines, the OIG deadlines, the OCR deadlines around HIPAA compliant systems, the Medicare. We don't have Medicare yet. That's a typo here. And the HRSA flexibilities. So you can see here we have May 11th, the OIG where enforcement discretion has come to a close. August 9th, the OCR HIPAA flexibilities will come to an end. November 11th, you will want to have established your patients virtually at that point and making headway so that by that in November 11th, 2024, you will have seen all of your patients at least once in person. And then December 31st is when the HRSA flexibilities expire. Okay. So hopefully this is helping you all. That's a recurring question we got was, can you please specify what the deadlines are? And you are correct to be confused about the deadlines. It is quite confusing because we have a couple more to share with you. So moving along to the payer. So this is an issue where everyone says Medicare is going to cover telehealth, or they say Medi-Cal is not covering telehealth. Well, it's not that simple. It turns out that there's a threshold question of whether or not they're going to cover a telehealth service. And then there's the question of what are the conditions of the coverage and who's eligible to provide the service, who's eligible to receive the services, where do they have to be, and a whole host of issues. And during the pandemic, there was a full range of flexibilities established. So we're going to go to the next slide. It gets more complicated because in addition to figuring out whether Medicare, Medi-Cal, or commercial payer covers the service, what types of services, the modality, whether it's audio only or interactive video, what providers have they authorized, what sites have they authorized. Turns out Medicare and Medi-Cal do not have the same exact policies, nor do commercial payers. So we are going to primarily focus on Medicare and Medi-Cal, but I have great news for you. But first, if you can answer this question, and I love who's driving my slide deck because you can read my mind. You're doing a great job. The good news is the Medi-Cal changes are already in place. So if you are delivering Medi-Cal services to patients, there is a high probability you are already adhering to the permanent changes that have been made in this arena. The Medicare changes are the ones that are complicated. So let's start there. It is not sufficient for Medicare to have a lot of different policies that are going to be permanently authorized, some that are going to be temporarily authorized, and then yet others that are going to be modified. They also have different categories of services called telehealth. And one of them is called virtual communications, which is frankly, it looks a lot, it quacks like a duck, it walks like a duck, but it's not called a duck. It's called a virtual communication. And CMS made this up a couple of years ago and proposed it. And basically it's a check-in. It's what it's considered is you're an established patient. You just want to check in with your doctor. And this was available to everyone, regardless of whether they were in a qualifying geographic location or originating site. So it meant anyone in an urban area, anyone from their home could do these check-ins. And it got around the restrictions in Medicare, which are statutory, which say you have to be in a certain rural area and you can't be in your home, which got waived during the public health emergency. So these virtual check-ins look a lot, it's like me calling on the phone or me doing an interactive visit, but it has to be really short. It has to be for an established patient. But during the pandemic, you didn't have to be an established patient. Everyone could do these check-ins. That is now gone away. What has also changed is also that you have to have direct supervision for when consent is provided. So you can't have what's called general supervision for this. So it can't just be done by the front desk and check off that consent has been given. So consent is a big issue already in the Medi-Cal program, and it's going to be an issue in Medicare, that it's going to be a lot more involved to document that consent. Okay, we're going to move to the next slide. So how many of you provide telehealth services to patients under Medicare? I'm not seeing a lot. Let's see, yes. Okay, I'm seeing a number of you. Okay, so behavioral health, mental health services, no surprises here, guys. Congress acted already. They basically have established that for behavioral and mental health services, we are going to see a permanent extension of the ability to use telehealth without those limitations on having to be in a rural area and excluding the home. So for mental and behavioral health, you can be in your home, you can be in any geographic location. Those flexibilities are going to remain in place. In addition, they're authorizing audio only communication. Turns out that audio only is controversial, even though there's a significant amount of evidence to support the use of audio only in overcoming structural inequality, particularly in the OCHIN network. We have data indicating that. We also are very pleased that FQHCs and rural health clinics can serve as a distance site provider for these services, and that will also continue. That is important because we are also in the middle of a behavioral and mental health public crisis as well, not just related to opioids, but a mental health crisis where we have shortages and there's a disconnect between the availability of individuals to provide those services in close proximity to where patients are. So we're going to move to the next slide. Really important, right, is payment parity for sustainability of so many of our practices, looking out across the delivery of care, particularly in underserved communities where payment doesn't always cover actual costs, particularly when providing care for uninsured patients. So payment parity is really important. And Medicare, that payment parity for virtual services will continue through December 31st, 2023. We do not know what will happen after 2023, but we'll probably get an idea when the proposed physician Medicare fee schedule is issued right before 4th of July this year. So we will have some updates to share with you all at that time on this particular issue, because this goes right to access and sustainability. So that's a mixed bag. The other issue that's a mixed bag is the issue of virtual direct supervision. So during the pandemic, direct supervision could be provided virtually. And that flexibility also will sunset at the end of this year. So once again, these are issues that we're going to be carefully tracking to evaluate whether those get extended further or not. And these are arguably within the discretion of the Centers for Medicare and Medicaid Services, CMS, which administers the Medicare program, to extend these permanently. So we will be advocating for that. So we're going to move to our next slide. Okay. So these are flexibilities that will be extended through December 31st, 2024. These were not at the discretion of CMS. These were directed by Congress. And these concern a broad range of Medicare flexibilities that you will continue to enjoy. We will, and I put that in quotes, you will be able to use in order to meet the needs, oftentimes, of underserved communities or individuals who are medically fragile and otherwise not able to access services. So in these, again, FQHCs and rural health clinics under the Medicare program can continue to serve as a distant site provider. There remain a range of services that can be delivered via telehealth, a broad range, which includes what are called Category 3 services. These are, it's unusual for Medicare to cover what are called Category 3 services. They will typically cover Category 1. We have a link. You'll be able to click on that calendar year 2023 Medicare physician fee schedule to look and see what those services are. And listed in there are also audio only specific services that can be covered and when they sunset. That's an official link directly to the agency that outlines both the interactive video and the audio services. So the good news here is the patient home. So this is really my shorthand way of talking about the geographic restrictions. So when I'm talking about geographic restrictions, I'm talking about two different things, and I'm conflating it. It's originating site and geographic restrictions. Originating site means where's the patient. So as you know, in the Medicare program, the patient had to be typically at some kind of facility. There was some carve outs for just a couple of services where they could be in their home, like end stage renal disease, dialysis related services until the pandemic. And then the pandemic hit and they said, okay, this antiquated notion that you have to be in some type of facility as opposed to your home, we're waiving that. And so the patient could be in their home. This is statutory, which means it requires an act of Congress to change this limitation. So Congress acted, but they kicked the can down the road and they said, we will decide this before December 31, 2024. So we're going to give you a little more time while we collect more evidence to decide if we're going to go ahead and open this up and allow it to be in home. The geographic restriction is you have to be in a qualifying location, a geographic location, typically rural, right? So if you're in an urban area, you would not be eligible for telehealth. This is statutory. It requires an act of Congress to change that. During the pandemic, that was waived so that you didn't have to be in a rural area. You could be in a urban area in order to have coverage. Congress acted and they said, we're kicking that down the road and we'll decide again in December and just before December 31, 2024. So the good news is for you, we have the rest of this year and all of next year, and hopefully it's permanently extended, and that is the focus of our advocacy work, okay? They also provided that certain services on that list that I mentioned above can be delivered via audio only. And Congress, when they permanently extended the behavioral and mental health authorization for wherever you're located, whether in your house and in Manhattan, you can receive these services. They added a little caveat. Congress said, you can do that and you're authorized, but you have to have an in-person within 6 months. And nobody knows how it got in there. Nobody supported that. But that's actually waived until December 31, 2024. And then that requirement kicks in for behavioral and mental health services. And we also will continue to see authorization for a broader scope of clinicians to deliver telehealth services beyond those statutorily prescribed under the Social Security Act, which was a quite limited category of clinicians that were authorized. So PTs, OTs, speech language pathologists, and audiologists will continue to be able to bill over that time. And then last, it also can be used to re-certify for hospice. Okay, so that's a lot. Yes, for the distance site, there are limitations. For example, Lisa asked here around distance site. Yes, for example, there are specified distance sites that are authorized. And so right now, FQHCs and rural health clinics are authorized as distance sites. And that was part of flexibilities under the pandemic. And those distance site requirements are payer specific. So you have to look at Medicare policy, Medicaid policy, and commercial payer policies to ascertain if you have patients that are covered in all those three different categories, whether or not, if you're an FQHC, for example, if you can be a distant site. Okay, so moving along. Oh, wait, before we move along, I just want to, again, level up on this particular set of timelines, since I think I counted 5 questions that we received in anticipation of this presentation around deadlines. And people brought up almost every one of these deadlines, and they're like, which one is right? It turns out they're all right. But if you apply them to the wrong flexibility, they're wrong. So this lays out for you the flexibility that expires and when it expires and some of the details around it. So you'll see here we have the DEA's flexibilities, we have the OIG's copay flexibilities, we have OCR's telehealth, HIPAA compliant platform flexibilities, we have the HRSA service areas flexibilities, and the Medicare flexibilities, which cover a huge number of issues that we just covered, like at breakneck speed, because we're trying to cover all the questions that you guys posed to us. Okay, next slide. Now, this is where we're going to take a deep breath, because we've just gone through a dizzying array of federal national programs. So these are programs that apply across jurisdictions, including California. So the good news here when we start to talk about Medi-Cal is that on January 1, 2023, the California legislature had already moved to extend permanently many of the telehealth flexibilities that had been in place during the pandemic for the Medi-Cal program. Now I can tell you this was not easy to secure some of these extensions. There was opposition, for example, to audio only telehealth. OCHIN was a leading voice and provided a significant amount of data from our network on the importance of audio only for those who were housing insecure and transportation insecure. They used audio only at like highly disparate rates to others to access their care, even within telehealth. So we're going to move to the next slides, and we're at 12:40. I do want to leave some time for questions. I'm going to leave 10 minutes. So we're going to go through the Medi-Cal piece pretty quickly. There's a range of telehealth policies, and then I'm going to talk about virtual policies, because these are also important in the state for you to be aware of. So I just want to start out, we did receive some questions that were licensure based, but I also want to underscore when you're talking about payer programs, they have requirements not only around state licensure of ability to practice in the state, deliver care. You may be located out of state. You can provide care to patients in the state as long as you're licensed in California. But if you want to deliver care to patients who are in the Medi-Cal program, there are some additional requirements that you need to meet in addition to licensure. So I'm flagging this here that you have to be enrolled and you have to be affiliated with a Medi-Cal provider group. Something important to keep in mind. Okay, next slide. The cover services for telehealth are essentially what come down to clinically appropriate evidence-based services that are appropriate for delivery via telehealth. I want to really underscore this bullet right here, because this comes down to nomenclature and using the right language to talk about the services and modalities that we are attempting to reach some kind of mutual understanding. The CPT codes are really important for understanding what the department will cover and what they will not cover. And these are going to be laid out by the state. So moving to the next slide, the department and Medi-Cal specifically do cover audio only telehealth and video telehealth, but there's some very specific requirements around billing for audio only telehealth that we'll get to in a second. And there is payment parity for versus in-person and virtual. So that's really important to keep in mind. I do want to call out Medi-Cal does characterize what's called asynchronous store and forward as telehealth. So this is an example of a government agency sort of being loose with the nomenclature around what they mean. I included a caveat on this slide you will get, and we do have listed in this slide our references so that you can go to the original source to find the guidance documents that we are referencing here. So in the next slide, we're going to talk about the audio only reimbursement requirements. So a patient may not be established using an audio only synchronous interaction except under 3 conditions. This applies not only to FQHCs and rural health clinics, but just across the Medi-Cal program and Medi-Cal beneficiaries writ large. I'm going to call out the first, or the 2 and 3 first, and then go to the first one. So the first is if the patient requests audio only, or if they don't have access to video. So those are like closely related. They're not exactly the same, but they're probably close. And then the first one really has to do, it's related to a sensitive service. So this listing of what a sensitive service is not exhaustive. You'll have to go and to the actual California code section for a further elucidation, but I think you get the general gist of what it is. It's things like mental and behavioral health, sexual and reproductive health, STDs, substance use disorder, gender affirming care, intimate partner violence, and similarly sensitive topics. So it's an set of exceptions that are pretty broad and provide a lot of flexibility, but they do also entail having documentation. So moving to the next slide, the department, much like Medicare, so Medi-Cal, like Medicare, has implemented some additional consent requirements that weren't in place during the pandemic. Again, these are things that should already be in place. Everything that I'm talking about right now was set up. California was out of the gate early, the legislature and the Newsom administration establishing these rules of the road. So consent requirements are also laid out here that you will need to have an appropriate script around your consent. Okay, moving to some very specific FQHC and rural health clinic requirements. So these are the requirements for FQHCs and rural health clinics for new patients and for established patients when using telehealth. And I'll just lay out here that in order to establish a new patient, you have to meet every single one of these requirements. It has to be that the patient has to be physically present at an originating site that is licensed or an intermittent site of the FQHC where the site is performed. That's pretty restrictive. And there also are some additional documentation and billing requirements that you can see here. And the service obviously has to be one that would be appropriate and that would otherwise be eligible for delivery as an in-service service. Now, this is where it gets a little confusing and ambiguous. So for established patients, you can use telehealth if they meet one of the following conditions. And I just want to lay out that the language in the guidance creates ambiguity. So this is really specific language, and this is taken directly from the guidance document around established patients. So I just want to say that you can deliver the service when the patient has a health record that was created or updated during a visit that occurred in the clinic or during a synchronous telehealth visit in a patient's residence or home with a clinic provider. Okay. So that seems a little ambiguous compared to the guidance around establishing a new patient. This sounds more permissive in establishing a relationship. It also has an exception. So these are ORs. So you just have to meet one of these requirements. The other one is for homeless patients or patients who are housing insecure rather. And the other is for patients who have been assigned through their managed care plan to the FQHC and rural health clinic, which that's really great news, right? So that means that if you have an assigned panel of patients, that is going to go ahead and qualify you for the use of telehealth because that patient is considered an established patient. Okay, so we covered a tremendous amount of ground. We normally would not cover this amount of information. I don't know if it's cognitively possible for you to have taken in everything that I just shared with you. It really represents literally probably 5 years worth of activities condensed down into about 40 minutes around some really broad regulatory issues. You will get the slides. There will be links, and I fully anticipate CTRC will be offering some additional programming on each of these specific topics to help support you in this process. So this gives you a global view of all the topics that you're going to be handling. So with that, I'm going to go ahead and hand it back to Becca.
Let's see, CTRC team, do you want to talk through your closing slides, or do you want me to open up the floor? There's just a couple questions in the chat.
Sure, yeah, just real quickly, a great reminder, now is a great time to put your questions in the chat if you have any. There's just a few right now. We wanted to share our upcoming opportunities for CTRC. Our next webinar will be on June 20th. It will be the future of telemental health, joined by Ray Barrett. So we're very excited to that. Registration is now available. Also to share that our annual summit is happening. This is our biggest event of the year, so it's a great opportunity to learn more about telehealth. We're also going to have a wonderful policy session where you will get to hear more from Sylvia. So please join us. Also, please know that there are scholarship codes available for health center staff, so please reach out to the CTRC team if you're interested. And yeah, we hope you will join us for our next opportunities. Next slide. And that's, I think, it for us. So I think now is a great time for questions.
Great. I'm going to start at the bottom and go ahead and work way up right now. Sue Ann just put in a question stating that the Medi-Cal audio only slide seems appeared to contradict the earlier slide about audio only for controlled substances needing a video visit and not audio only. Sylvia, I don't know if you want to tackle that.
I sure do. So, so this is where maybe if we go back, let me tell you the slides we should go back to. Let's go back to slide 25. So this is where it gets really hard for folks, and it's understandably why it's hard. So I want you to take a look. We were talking about payer telehealth insurer coverage. DEA is that upper left-hand corner around regulation of practice. So when it comes to controlled substances, so this is apart from other prescriptions. So the federal government only regulates the prescribing of controlled substances, right? So is everybody's with me, right? So this is things like buprenorphine, Valium, Percocet. So the federal law says we are going to decide who and when can prescribe these and the conditions. And we've decided for these subset of medications, we are going to have specific rules around the people, the place, the modality. And you as a payer can decide what you want to do, but the federal law says for these activities and this prescribing, you cannot. So if I, as the DEA, say for these controlled substances, you cannot prescribe a controlled substance via telehealth, via audio only, for everything except for buprenorphine. So I'm going to have you go to slide 10. Then I, the federal government, trump anything that a state would say or that any payer would say. So it's an excellent question. And it's one of those nuances that can get really confusing fast. So I'm going to say it again. So Medi-Cal is saying, and Medicare is saying, there are certain services we're going to allow, we're going to pay for. I'm a payer. I'm willing to pay for it, and these are the conditions, and I'm allowing for audio only. And the federal government is like, that's great, but if the service involves prescribing a controlled substance, I win. I trump whatever you say, and my rules apply. Okay? So for the schedule 2 through 5, if you can provide a service, like I can provide therapy via audio only, right? But the actual prescribing of the service, prescribing of the treatment for purposes of dispensing a controlled substance that service has to be rendered either through an interactive video interaction or in person. Otherwise, by federal law, that is not a legal prescription. Does that help? Okay, great.
Okay, great. Thank you so much for that. Let's stay on the topic of DEA prescribing and telehealth and everything that goes within it. Claire has a pretty specific question stating that at their FQHC, their providers cover for other providers in providing refills for controlled substances when that provider is out of the office. So question here is, will the DEA proposed rules affect this since the refills are provided without the covering providers having established care with the patients prior?
So I love your question because that is just the fact pattern that we brought up in our opposition to the proposed changes that were laid out. Because if you have a practice, whether it's an FQHC or a group practice, it was ambiguous with regard to what the DEA had initially proposed as a flexibility. And we were like, well, it's really not clear if in the fact pattern you just offered, which is basically a group practice arrangement, right? As an FQHC, you also may have established patients, but you may also have flexibility about the patient seeing other providers within the group. And so we are continuing to advocate that whatever the final permanent rule is, that it accounts for those types of arrangements. And so we do anticipate some pushback, just so you know, because while payers like Medicare and Medi-Cal are very accustomed to this idea of a group practice, if you are a DEA registrant, you will know that they are quite adamant that their relationship was with the individual registrant and the obligations run to that individual registrant. So there's a bit of a culture tension with the DEA. And I know we are close to time. So I think we can take maybe one more question and then the rest we can follow up with in the materials that we make available.
Great. I'm going to grab one question that should be pretty quick. It was from earlier that Lisa had submitted, asking if the copay can be billed versus collected at the time of the telehealth visit. I believe that this is in response to that OIG flexibility.
Mm-hmm. So the copay, you have to have a mechanism in it for billing it and for seeking payment. I do not believe at this time, meaning I do not know at this time if you have to collect it at that time. Like when you're rendering the service, and I don't believe that you do, but I don't know that unequivocally, and so we'll verify that. All I know is that you do have to have a reasonable process in place for the billing and collecting of the copay. It doesn't specify how you do that. It will be evaluated, however, if it appears that it is merely a subterfuge that you are attempting, that you're saying you're billing, but you're really not making any meaningful efforts towards collections, right? So there does have to be some kind of meaningful process in place. Bearing in mind, however, that if you're an FQHC, that the collection of a copay, that you're evaluating ability to pay, and their sliding fee schedules sort of independent of that issue. So they shouldn't be conflated, right?
Mhm.
So remember, if you are in Medicare or Medi-Cal, you're already a covered patient, whereas HRSA also, if you're an FQHC, you could be uninsured, right? So in that case, there's flexibility around payment based on your fee schedule, around ability to pay. So those are separate, right? We're talking about co-pays as they relate to a Medicare or Medicaid beneficiary.
Thank you for that. Yeah, so I think we're at time with questions, so I'll hand it over to the CTRC team.
Thank you both so much. That was a lot of helpful information for me, and I'm sure for everybody else in the room, to understand all these different dates and timelines. Real quick, everybody, if you wouldn't mind, we have a quick poll. We'd like to know how you found today's session. If you have any feedback for us or comments, please feel welcome to put them in the chat as well. But we'd just like to know how you found today's session. If there's any topics or suggestions, we'll also take that in the chat. So thank you so much. And a big thank you to Sylvia and Becca for joining us today and offering so much knowledge and insight. We really appreciate your time and expertise towards the CTRC. So thank you so much for being here with us today. And I'll also follow up to say, as Sylvia mentioned, we're going to send all these materials. So all the resource links, you will get a copy. We will email them to everyone who registered and also have them available on the CTRC website. So everyone will get that information by the end of the week. And yeah, so thank you all very much. And I hope you have a great rest of your day. Thank you. All right. Call it in. All right. Bye, everyone.